Good evening. Today is August 26, 2020, and it is 5:37 p.m. As a quorum of the Board of Managers is in attendance via our video conference, I would like to call to order the meeting of the Central Health Board of Managers. The first item of business is public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 4 p.m. today. Jana, did anyone register to make comments?
Good evening, Madam Chair. We have 3 members of the public signed up for citizens communication tonight. And so since we have those folks signed up, I'm going to read our guidelines for public comment at this time.
Okay, so Jana Allen of the Central Health Communication Department will briefly cover the guidelines for the public communication portion of the meeting and will then introduce all commenters in the order they registered. Once Jana has recognized you, please unmute your phone or computer, state your name, and provide any comment. There's a 3-minute limit for comments per board rule. Jana?
Thank you, Madam Chair. To be recognized to speak, you must request a speaking lot using our public communication online registration form or by leaving a voicemail by 4 p.m. the day of the meeting. Individuals are asked their preferred language as they register to speak, and both the online form and voicemail greeting are available in English and Spanish. All speakers will be recognized by name and in order that their speaking request was received. Please keep your phone muted until you are called on to speak. Please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Once again, speakers will be muted at 3.5 minutes to ensure the efficiency of the meeting. Speakers may not donate their time to other speakers. As a courtesy to others and to be respectful of time constraints, please try not to repeat other speakers' comments. Depending on the number of speakers and the total time being spent in the public communication portion of the meeting, the board chair may, in her discretion, impose additional limits on time or comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. And with that, I will call on our first participant in public communication, Zach Timmons, on behalf of Good Apple and Dell Medical School. Zach, if you could—
Welcome, Zach.
Thank you so much. Can you hear me okay? Great. Thank you so much for having me. My name is Zach Timmons, and I'm a 4th-year medical student at Dell Medical School, as well as the co-founder and CEO of Good Apple. Thanks again for having me here to share a little bit more about my team's work addressing food insecurity here in our community. So as many of you know, there is much more to health than what physicians do inside of the hospital. In fact, by some estimates, about 80% of our health can be attributed to factors outside the clinic. Things like educational opportunities and financial stability and food insecurity can actually have a bigger impact on people's health than a single prescription or surgical procedure. And I'm fortunate enough to be part of a program at Dell Medical School, and I think our greater Austin health community who really understand these ideas and the importance of not only identifying these issues, but also creating interventions and programs to begin to address them. So as part of my 3rd year at Dell Medical School, also known as our growth year, I was provided the opportunity to work on food insecurity for an entire year. And I'm excited to share a little bit more about our program. So to provide a little bit of background on food insecurity in Austin, about 1 in 6 Austin residents, including over 50,000 children, are unsure of where their next meal is coming from. As a future healthcare provider, this is especially troubling for me, knowing what we know about food insecurity and it's causing worse health outcomes. However, we're also super fortunate here in Austin to have a ton of organizations that are working on the issue. In fact, we have nearly 60 food pantries, one of the largest food banks in the country, and an incredibly thriving farming community as well. So with this in mind, I thought there might be an opportunity to collaborate between all of these partners, and our team since last November has worked to launch Good Apple, which is a produce delivery company on a mission to address food insecurity in Travis County. And for every box of produce that we sell, we provide another box of produce directly to a family in need. And the way we came to this solution was really talking to our patients. We found that there were two main barriers to accessing healthy food. The first being transportation barriers. Many families, especially those without their own access to transportation or living in a more rural community, have trouble getting to food pantries and these incredible, opportunities to access healthy food. And additionally, a lot of food pantries, because they rely on volunteer workforces, have limited business hours. And so for many families who are working, it can be tough to kind of make the decision between going to a food pantry or taking time off work. And so what we've done is created a program that addresses both of these barriers, and we deliver food directly to the doors of families facing food insecurity. So we launched this program back in November. We were really excited to get it off the ground, started off delivering about 50 to 100 deliveries per week, and then COVID-19 hit. And I think what we saw was an incredible increase in the need, but also, I think the reason that I'd like to share it today is incredible partnership across the Austin community. And so we launched a Stay Home, Stay Healthy program, which is delivering food now to the elderly and the immunocompromised across the city of Austin. And we've partnered up with many clinics in Austin, including community care and other housing authorities and community groups such as Go Austin, Vamos Austin. So really been able to reach out and reach those people who are most in need. It's been an incredible partnership between the Central Texas Food Bank, the University of Texas, Dell Medical School, community care, and other organizations in Austin. And since launching the program in March of this year, we've served over 18,000 people, including delivering over 550,000 pounds of fresh produce and other pantry staples directly to the doors of some of our most vulnerable community members. So it's been really exciting. I just wanted to share a little bit more about that work, and would love to chat with anybody afterwards if they're interested in learning more. But thank you so much, Central Health, for being a part of that. Many of our clients for the program have been recommended through clinics. So I think it just shows one way that, when we come together and partner on an issue, we can really make a difference. So thank you so much again for having me today. I look forward to the rest of the discussion.
Thank you.
Thank you very much. Keep up the good work. I'm well aware of the Good Apple, and I think you were fortunate enough to win another a competition too a few months ago. So thank you.
Yeah, thank you so much.
Thank you again. Our second speaker for public communication is Anupama Kapadia. And please correct me if I've mispronounced your name so we can all say it correctly, but she's our second speaker for today.
Well, first of all, that was great pronunciation, and I go by Anu, so I hope that makes it easier. Well, good evening, everyone. It is an honor to be here with y'all today. My name is Anu Kapadia, and I'm the inaugural ambulatory internal medicine chief resident through the DelMed residency program. I share my clinical time between the clinic and the hospital. I actually voted on Proposition 1 when it first came out in 2012, and since then have been working toward my goal of being a primary care physician and an advocate for our patients with CUC and DelMed. I was drawn to this program and community for the people, my peers who are like family, faculty who prioritize patient-centered care while creating a safe learning environment, promoting compassion and curiosity, and most importantly, the incredible patients for which we have the privilege to care. Now that I've graduated, I continue to strive towards my goal of being a primary care physician leader advocating for my patients in our community. As we all know, our clinic patient population at community care has been particularly impacted by COVID-19. Most of the patients we see in clinic have at least 2 to 3 chronic medical conditions that already put them at high risk of severe illness, in addition to the various social determinants of health that increase their risk of contracting COVID-19. None of us ever imagined that we would be in training to become doctors during a pandemic, and it has been full of challenges. Navigating management of a new disease that can wreak havoc on the body, bearing witness to the death and suffering of so many people, and providing social and emotional support to patients and their loved ones has been no easy task. But it's the teamwork in clinic, both within our program and with all the disciplines we work alongside, that keeps us going. We learn together because we know we are in it together, fighting for our patients' lives and their well-being. Let me give you a glimpse of our resident clinic. With permission, we have called employers so that patients wouldn't lose their jobs due to illness. We've connected our patients with free legal services so that they may have the chance of getting a transplant. We've called Safe Alliance with our patients as they navigate safety while surviving trauma. We've gotten to be there for our patients as they as they've accomplished their dreams. I'll never forget seeing one of my patients who's been through so much come in for a quick appointment in her cap and gown where we got to take a selfie before her graduation ceremony for her degree in counseling. We've worked with and learned from our incredible extended care team, including nursing, clinical pharmacy, case management, dietitians, MAs, and MACs, to help our patients stay out of the hospital and live their best life. One of my patients has late-stage kidney disease and is unable to read. Our amazing case management team has her come once a week to fill her pill box so that she takes her medications appropriately. If her medication regimen is just a little off, her kidney disease is so severe she'll land right back in the hospital. And when our patients unfortunately end up admitted, we visited our patients in the hospital so they could see a familiar face with the hope that they'll feel a little less scared and follow them in clinic after discharge. Our residents are driven to constantly grow and are eager to find ways to improve both the level of the individual and the system. My colleagues and I have engaged in quality improvement work to improve blood pressure and control, given that hypertension is a silent killer. Around the holidays, residents have led blanket and food drives as another way to support our patients. And in the time of COVID, we were quick to transition to telephone care so that the care of our patients did not stop. Our patients do more for us than we could ever do for them because it is in caring for them that we find meaning and purpose. It's truly a privilege to serve our patients, and I can't imagine being a physician in training and now a physician no longer in training anywhere else than here.
Thank you.
Thank you for your dedication.
With that, our last speaker for public communication is Snehal Patel. Snehal, if you can unmute yourself, you'll have 3 minutes.
Thank you. Good evening. I'm Snehal Patel, an internal medicine and hospital medicine physician at Dell Seton Medical Center and Dell Medical School. I'm here to speak a bit about our experience with providing care for adult COVID-19 patients admitted to Dell Seton.
I'm having trouble hearing you. Can you get closer to your speaker?
Sure. Sorry about that. Can you hear okay? So I'm here to speak a little bit about our experience providing care for adult COVID-19 patients admitted to Dell Seton Medical Center with a particular emphasis on promoting health equity. So a bit about our patient population at Dell Seton. We are a little bit different from some of the other hospitals in town. So during the first months of the COVID-19 pandemic, approximately 80% of our patients self-identified as Latinx or Hispanic, and for 66%, Spanish is their primary language. About 45% had never seen a primary care provider, and we're seeing high rates of previously undiagnosed diabetes, hypertension, and other comorbidities at presentation in our patients. Preliminary data on social determinants show that more than 85% of our patients are unfunded or publicly funded. About 40% report housing instability, and about 35% report inability to afford medications. So early on, it was very clear that we needed to develop a transformative, integrated health system that prioritizes care toward the vulnerable and marginalized communities in order to provide effective care for our patients during this pandemic. I'll highlight how our approach has been unique to meet some of the needs of our patients. In the first month, we developed a communication strategy to engage our patients and families throughout their hospitalization, to improve our post-discharge process, to support contact tracing and public health messaging efforts, and to build trust in the community during this crisis. We developed a process to assess health-related social needs, assets, and social determinants, and work to address these needs and develop wraparound social services through partnerships with community organizations and the city. We ensured our patients had post-discharge follow-up care, prioritizing those who had not seen a primary care provider before, allowing for a greater than 90% post-discharge follow-up rate for our patients following with community care providers. We developed a multidisciplinary and interprofessional therapeutics and informatics committee to evaluate emerging evidence and produce local consensus recommendations to treat our patients as effectively as possible. There's much more I could talk about here, but I want to briefly look at our outcomes. Initial data compiled through Vizient, a national data organization that collects data from academic medical centers and large health systems, show that across admissions through June, our mortality index, that is the observed rate of death divided by expected rate of death, was 0.42. That is, patients admitted to Dell Seton Medical Center with COVID-19 were less than half as likely to die than would be expected. Compared to other safety net hospital systems in Texas, our mortality and hospital lengths of stay have been substantially lower with similar severity of disease. This data comes with the caveat that we're still in the late phase of our current local surge and we're still analyzing recent data. I'd say there's significant value in the public-private partnership between Dell Medical School, Ascension Seton, and Central Health, and our processes and outcomes speak to the importance of centering our collaborative work around our patient population and really prioritizing initiatives and committing resources to advancing equity. Though we have much work to do around this, we have tremendously dedicated and highly trained staff, nurses, social workers, students, residents, and faculty who have brought their everything to really build improved ways of caring for all our patients in this time of crisis. Thank you.
Thank you so much for your important work. Deeply appreciate it.
Thank you. Madam Chair, that concludes public communication for this evening.
Thank you very much, Jana. And thank you to all of those who took the time to come to our public communication. We very much appreciate it. Members, we will now proceed to the consent agenda. C1, receive and accept the July 2020 financial statements for Central Health and the Community Care Collaborative. Is there a motion? Manager Bell?
I move that the board approves consent agenda item C1.
And second, was that Manager Valadez? So we have a motion and a second. All in favor, aye.
Aye.
Opposed, same sign. Any abstaining? Okay, members, thank you very much. Members, we will take one item in our regular agenda out of order this evening. Item 6 will precede item 5 due to the closed session needed for item 5. So we're now moving to our regular agenda. Number 1, receive and discuss an update from Dell Medical School at the University of Texas at Austin, including how it supports Central Health's mission and a COVID response update. Dean Clay Johnson will be presenting. Dean, I know how busy you are. Thank you for being with us this evening.
Well, absolutely my pleasure. I know you all are also very busy people, so thank you for hearing from me. And I was pleased to hear from 3 of our sort of colleagues and students and residents about what they're seeing, what they're doing. So a lot's happened in the last year. And I'm not going to read you what's on this slide, and we sent you a bunch of materials as well that you all can spend some time reviewing, and I'm sure you have already. I'm just going to focus on a few milestones for this year, given my 5 minutes, and then obviously I'm here to address any questions. This was a big year for us. This is a momentous year. We graduated our very first class. Unfortunately, not with the fanfare and celebration that we had hoped, but nonetheless with the kind of impact that we had hoped with the students and launching them off into important careers. 22 of them, of our 49 graduates this year, will stay in Texas, and 11 of them in Austin, and that's actually more than we expected. We have small residency programs, and so to hold on to that many was really wonderful. We've grown the residency programs quite a bit. You can see that number 343 on your screen. That's up from 308, and they've provided a substantial amount of care and seeing, this is in terms of hours, but also seeing a very large number of patients in some of the settings that you just heard about, both in the clinics and in the hospitals. We've grown some new programs, and we'll continue to add new programs with community care and Central Health, but also new programs for the community broadly. We've expanded quite a bit in the pediatric neurosciences, an area that we did not cover well previously. Added a heart transplant program, a fetal care center, added the Department of Health Social Work, which, as you heard from actually all 3 of those presentations, refer to the importance of social work and our partnering with them in creating programs that really acknowledge the inequities in our community and the importance of social determinants in addressing health issues. We've also had some maturing programs, ones that we're really proud of that we've worked on with you. This year, the GI program, which you have heard about separately, so I won't go into detail on, we view as incredibly successful, and actually hope that it will become a national model for how to provide that kind of really high level expert care without the inefficiencies inherent in those current systems. similarly for dermatology. And then the colorectal screening program has also been very successful, not ours alone. Community care has contributed also with a number of changes that also contributed to the more than doubling of primary care patients that should be screened for colorectal cancer getting screened. So dealing with a chronic inequity in our community. And we've just heard that that program will be extended. So we've got another couple $2 million coming into that program so that we can expand it and continue it. And again, I think another example of how we leverage our expertise and our position to bring new resources to the community to address some of these areas that we prioritize together. And then on the COVID response, I mean, I think that's been a huge area of focus for all of us. And as you heard from the three public presenters, that has been a focus for them as well. I think there are a few things to point to that I'm particularly proud of. One, I just want to say that the coordination has been amazing. So being able to pull together and really work with Central Health, with the CCC, with community care, the great leadership that's been shown by all those entities. Community care is just amazing work in getting testing out and filling gaps that Austin Public Health could not fill, and being able to work very closely with us in programs too that we've collectively prioritized. So our contributions there are all over the place. Some is just in leadership and creating modeling and using that to guide both the local response, but also the state response. And we have people that sit on the governor's task force. And then the work that we've been doing with HACA and trying to improve services in home health in the HACA system. But I think, and then the exchange for creating more PPE. You've also heard about Good Apple. It's a pretty amazing program to be created by a medical student in the middle of their medical school training. Huge impact of that program. Again, perfectly positioned within COVID, but has potential to deal with that issue well beyond. And then, but two areas that I just want to emphasize. One already that Snehal brought up, our outcomes are amazing. So most of the Central Health folks have been cared for at Del Seton. In that, the outcomes there, whereas we're usually having to deal with outcomes that are more difficult to manage because of inequities, because of racism and social determinants that make it really hard to achieve the same outcomes that you can with wealthier folks. The reality is the outcomes are substantially better. Less than half the mortality for each COVID patient, way better than Parkland, way better than national measures, way better than what we see across the city. So these are really remarkable outcomes in there because of our frontline teams. And again, you heard from two of them today. So I think that's just remarkable. And it shows the promise and delivering high quality care to the people who need it most. Anybody who walks in that door gets high quality care. And we hope that hospital continues to serve the community that needs it most. And the second is our response with the homeless. That's actually been a really remarkable partnership. APH is part of that partnership. Community care is critical to that partnership. And faculty that we share together are the ones who've led that. By directing, early on, we recognized that this was going to be a major issue for outbreaks. It has been for every other city. And so we went out and got philanthropy, over $1 million that we could devote to this problem. And being able to bring those resources, being able to work in partnership the way we have, it meant we didn't have to wait for others. We could just go and do stuff. And that has been highly effective. So getting out, getting the testing done quickly, working with, the county, the city also did great things in terms of setting up housing, supportive housing, that sort of thing for folks who were positive or at risk. And that's also been tremendously helpful. But we didn't have the kind of outbreak that every other city has seen for the homeless. In fact, it's one of the sort of healthier groups in the community in spite of the vulnerability in them being out there in close quarters and in unhealthy settings. It's a remarkable success story, one that we did together. So looking forward, there's a lot coming up. I mean, I think we can't really look past COVID yet, and so we are continuing to do that work again with you all, and we're continuing to plan to assist Austin Public Health, but not rely solely on them, similar to the approach that we've taken with the homeless. And we'll do that alongside Central Health, the CCC, Community Care, and other partners. So I'm excited about that work. I'm not excited that we have to do it, but I'm excited that we are rising up to get it done. The Austin State Hospital, the construction continues. We're hopeful that that will complete, but obviously we're going into a difficult cycle, and we'll see. But a lot of interest in that. The Pink Bus has been relaunched. We'll get that going and hope for other cancer programs to follow and for us to develop those as a community. And then another example is is being able to provide psychiatry telemedicine, both into initially primarily into the schools as a free service, and it's another program that is a statewide program, but led here, and will have, we think, a great impact on our community, particularly as we've seen the mental health issues become more and more problematic because of COVID. So those are the primary things that I wanted to present in my 5 minutes. I think I stuck with my 5 minutes. So we probably don't need this slide anymore, and I'm here to answer questions for as many as you have.
Dean Johnson, thank you so much for that excellent presentation and for all the work that you and others have been doing tirelessly, certainly for many years, but I think it's been, we know, an extra strain with COVID, and we appreciate all that you've been doing. Members, I'm scanning, so if I don't see a hand, shout out. Manager Jones, I don't see a question. Manager Bell, Zuniga, Manager Zamora, Manager Valadez, yes.
Manager Mustatif had her hand up first. I'll let her go.
Excuse me, again, it's hard to scan all the squares here. Manager Mustatif?
Well, thank you. Appreciate it. First of all, thank you for coming and sharing these wonderful students with us and doctors. Congratulations on the first graduation of the class. I attended it online. It was beautiful. Literally had goosebumps. So I was really proud of them. I remember the day that you established this amazing medical school. So thank you for all your efforts and for your leadership. As you know, DelMed has done a phenomenal job for our community, and I cannot imagine this community without you, especially during these unprecedented times. So thank you for everything that you do. And also, I was very pleased with the CIPRIT grant that was awarded. That's phenomenal, for expanding colorectal screenings for our community, especially for underserved communities. That is something personally I am a strong advocate for, and also expanding the mammograms with the Pink Bus. So I look forward for that. And again, thank you for everything, and especially that you mentioned you rose up and got everything up and running and doing. I know it was not easy. All I can tell you is, again, I can't thank you enough for your leadership and amazing work that you have done. Thank you.
Thank you. Manager Valadez?
Medical.
Manager Valadez, there you go.
I want to thank the speakers from your medical school, the graduates and the students that I think that are still there, for the excellent participation in our community, and for the percentage of people that are remaining here, Dr. Johnson. I'm very proud of that. Thankful. That's what we were hoping for. With respect to I think I understood you to say, to give kudos to your relationship with Seton in working with our MAP patients. That's correct. Did I hear that?
Yes. I mean, I know there are complicated issues with Seton, but in terms of what we can do in the hospital, our partnership with Seton has allowed us to provide this sort of level of care in the kind of outcomes that we're seeing.
I'm especially appreciative of that. But I was just curious as to whether or not there is anything that you can do at the Dell Medical School to help Central Health and Community Care continue to serve those patients that are being served at Seton Dell Hospital, that we may not necessarily have data about, so we can follow up with them, so that we can continue to take care of them in our community and provide services to them. I don't know. I'm hoping that we have that kind of understanding, but I'm not sure. Do we or don't we?
Yes, I would say that on the hospital side, we are working very closely with them to be able to achieve these outcomes. It is that partnership that makes it happen. And there, the nursing ratios too are more favorable there, and that's certainly contributing. So it's not all, doctors and what they're doing. It's the stuff that Seton is managing. Not everything has gone quite the way we had hoped, but it's not Seton's fault. And, we've had conversations about, for example, translation, and then, that getting adequate translation, because that's a critical function for us providing this level of care for this population. But ultimately work through those things. So on the inpatient side, that all works great. Snehal mentioned some of this. The transitions to outpatient care, they're always complex, particularly for these patient populations. And there is more we can do as a community. How much of that is Seton's responsibility versus community care on the receiving end versus the city and county versus pulling in other nonprofits? That's partly why it doesn't work. It's not, we are not working as a single unit as much as we should be, and not just in this, but in other things. And that's limiting our potential to actually get to the next level.
I agree. And as we give you $35 million a year, I'm curious as to whether or not there's a convening that can occur if we have been unsuccessful in doing that. Is there something that you can do to make sure that those partnerships are established, are solidified, and that each entity become responsible and accountable for their part in filling those gaps and improving the overall quality of care, so that our community quality of health in turn rises to a different level? Is there something that you can do, Dr. Johnston?
You're pulling at my heartstrings here. This is something I've been interested in since I got here. It's the promise of the CCC, and it was built on a wonderful vision.
That's right. But
the structure of it hasn't proven worthy of the vision, and it is weighing us down, and it's weighing all three major partners down, right? So we are all affected by it, and it's slowing our ability to progress.
As we know that, are you working on something that you can share with our leadership and the leadership of community care and the leadership with the other entities who are going to be here in the community, having to support those people who are going to leave the hospital and transition into their neighborhoods where they're not getting the supports that they need?
Well, we'll continue to push that as hard as we can. Everything that we can do, we will continue to push, and we'll continue to bring the partners together wherever we can.
Okay.
There's fundamental issues that I hope can get resolved that could be just completely liberating to allow us to, and then re-envision how, the same vision, model healthy community. Now, what's the underlying structure to achieve that? That needs the first step to be peace between the two major entities in that, which is, it is not us, but we will continue to push and try to bring you all together as best we can.
I have one last question.
Dr. Johnston, Manager Valdez? Yes.
And this is with respect to the high number of negative, I guess, or positive COVID testing in the Latino or Latinx community, the population here. I was listening to Dr. Patel speak, and when he's talking in terms of 80% of the population that they have there at the hospital under COVID, and then 60-something% of those were non-English. Over 60% was non-English speakers, which is what I am. The non-English speaker community is what I have a problem with not being served appropriately. And I don't know whether or not, when I hear Dr. Escott speak, I hear all the numbers coming out, and I don't know whether or not that is the language barrier, is the actual wall to be broken down in order to let that population truly access healthcare. They're not able to, and if in the provision of services and the provision of information that's out there in the outreach efforts, in the and maybe the providers fit with the patients. It's difficult when you're having a translator as opposed to a person as it's an MD or a doctor or a nurse practitioner that speaks the language or culturally comes from that population, to be able to communicate with them and to help educate them. But that starts at the bottom. That starts at birth, and building that capacity for understanding disease and how it impacts our quality of life. But with respect to the APH and with the support of University of Texas Medical School, why have we failed to turn around the high positive COVID tests in our COVID percentage in our Latino community and the number of deaths? What can be done about that?
Yeah, major contributors to that. That's been an incredible source of frustration. We saw this very early on before
That's
it was
right.
really being discussed, and we brought this forward. And we've, again, I don't want to air issues publicly. It has been difficult to get the partners to all work together in this space. One of the first triggers was that we took anyone who could work at home or didn't need to work, and they protected themselves. And then the construction industry, for example, continued forward unabated, and we tried to get testing out to the construction industry early on when we started to see, as we were doing contact tracing, that a number of cases were coming. So this is, and there were barriers put up in front of to do that testing. This is one example. There are many others. Language is an issue, but I think this is very predictable from who we didn't protect in the very early days. And then your question about how can we get beyond it. So we're frustrated. We've decided that, sort of like our response to the homeless, that we need to have something similar go on with the Latinx population.
That's right. I agree.
And so we're working on sources of philanthropy so that we can move on our own. And it won't just be philanthropy. We just need to supplement it with philanthropy. And then we'll work very closely with you all and with community care. Jason and I had a conversation about this earlier this week. And so our hope is to continue to push that forward independent and not wait for permission.
Well, I believe that this is a systemic issue. And what we're seeing now is finally shining a light on where those gaps are and the flaws. And so what we need to do is work together. If there's anything you can do to help us work through this problem, and making sure that the people who are living in the shadows, the people who are may not necessarily have status, the people who don't speak the English language, that those are the people who are out there doing all the essential work. You know, they're out there they're having to work because they're hourly wage, no insurance, you know, multiple families living in one apartment, et cetera, you know, not necessarily having their needs addressed to in a school system that is not providing bilingual education the way they should, et cetera. So these are all issues that may not necessarily all fall under our purview as a health care district. However, we work jointly, and those governmental entities should be our partners in making sure that we have the model, a comprehensive model in place that will address each of them, and each of them can be held accountable for providing those services. And if they're not, we shouldn't feel ashamed for calling them out for not providing those services. And I just wish, Dr. Johnson, that you and your doctors, as I can see they are, have understood that responsibility. And I'm sure they're faced with equal frustration and sadness as we see more and more people die when they shouldn't. And so it's just very frustrating for me. And I just want to let you know that anything that we can work together, as opposed to me saying something else, anything that we can do to work together, I would ask you to please extend your arms to Mike and to Sherry.
Thank you. Thank you, Manager Valadez. And thank you, Dean Johnston, very much. Managers, are there any other questions at this time? I'm scanning and not seeing any. If I miss you, please shout out. All right. Well, thank you very much. Thank you for spending the time with us. And I see some other members of your team here. Dean Johnson, I see Minnie here. Minnie, thank you for being here with us. And we deeply appreciate all that you do for our community.
Thank you. We also very much appreciate you and all the work that you all are doing. So thank you very much.
All right. Thank you very much. Members, we will now move on to our next item on the agenda. Item number 2, receive and discuss a presentation on the proposed Central Health and Community Care Collaborative Fiscal Year 2021 budgets, including related strategic objectives and fiscal year 2020 end-of-year estimates. Members of Community Care Collaborative CCC budget will not be presented this evening. We will receive the staff presentation on that budget in one of our upcoming meetings, so please hold any questions regarding that until the staff is prepared to present that budget item. Jeff Canoto and Lisa Owens will be presenting. Jeff and Lisa, would it be helpful for me to also bring up agenda item 3 at this time and agenda item 4, or do you want to take them one by one?
It would be fine if you could bring them all up at the same time. That would be great.
Okay, so I'm going to also bring up agenda item 3, discuss and take appropriate action on a proposal to consider a tax increase for Central Health's proposed property tax rate for fiscal year 2021. Members, as a reminder, this item is the preliminary action that we must take in connection with the tax rate for fiscal year 2021. Tonight, we will vote on the proposal to increase the tax rate to no more than 11.0306 cents per $100 of taxable property value for the 2020 tax year, which will support the Central Health fiscal year 2021 budget. The final vote on adoption of the tax rate is tentatively scheduled for September 16th, after we have had a community conversation on the budget, a public input session on the tax rate, and the statutorily required public hearing. The date, time, and location for the required public hearing on the tax rate increase proposal will be formally announced in the next agenda item, which will allow staff to publish the required public notices in the newspaper and on our website. And then agenda item 4, set the date, time, and location for the public hearing at which the Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2021 tax rate. I'd like to note for members of the public watching the meeting this evening that the tax code requires us to hold the public hearing for our tax rate setting in a publicly owned building. Because this requirement has not been waived due to the pandemic, we will follow the code and provide access to the hearing in our offices. However, we strongly encourage members of the public to take advantage for their own safety, health and safety of the online and telephone options to participate in the public hearing. We will allow any member of the public wishing to comment on the proposed tax rate to do so via our video conference link or by telephone. So Jeff and Lisa, I'm now going to turn these items over to you to present. Thank you.
Thank you, Chairperson Greenberg. Appreciate opening up all three items. Once again, this is our fiscal year 2021 proposed budget, and I just want to highlight we're still in a proposed budget status, and so that we are, as Chairperson Greenberg mentioned, we are requesting a couple of action items this evening that are part of the proposed budget process. So certainly I won't repeat those. She excellently pointed out what they are. But I will point out on the first item, it will be a roll call vote, which is a little bit different than the votes that we typically take. Next slide. Before we get into the budget, I've been working a little bit on our healthcare delivery expense. And I realized that when we establish our healthcare delivery budget, that it can get confusing because of all the different elements that are contained within that budget. And I also realize at times there are fluctuations as not only the level of services that we've provided over the years has increased, but there are also fluctuations related to how we budget, in particular the contingency reserve and how that relates to the total spend or the total budget. But one really good way to look at our healthcare delivery expense over time is, what do our actual expenses look like over time, and what is the trend of those? And so I've prepared two charts. The first chart is Central Health proper, and the chart below that, and this is consistent with some of the financial reporting that Lisa presents, where we combine both Central Health and the CCC, and we look at more of a combined spend. And so these two charts look out over a period of 7 years, 2013 to 2019. And we're looking at actual expenses and any trends or fluctuations that we see. And you can see by looking at both charts, regardless of the chart, the dotted line is the trend line as it relates through that period. And they both have an upward trend, which I believe represents the increases that we have reported on our service level reporting as it relates to the volume of care that's provided to the community. Specifically looking at the charts, you'll notice that both charts show a peak in 2016. And so a logical question might be, what is that peak and why was that so high? One of the events that occurred during the first phase of the 1115 waiver program, which again was a 5-year period, was a lot of the intergovernmental transfers. Again, these are dictated by the state as far as the timing, fell significantly behind. And there was a point in 2016 where we were, in essence, sending or providing intergovernmental transfers for 2 years. And so there was certainly a spike in 2016 because those are very large expenses that occur for both the uncompensated care program, and the disproportionate share program. So there were some delays. I think the uncompensated care program was the program that had the most significant delays, and those were all caught up in 2016. And so that I think explains the spike that we see in 2016. But overall, again, I think both graphs are consistent as far as an upward trend on the investment that that both the Community Care Collaborative and Central Health has made as it relates to delivering health care to the community. Next slide. So this is a real familiar slide, and I'm not going to spend much time on it other than to tell you that it has been updated for fiscal year 2020. It's a comparison of the major Texas hospital districts, both the property tax rate and then the percentage or burden of all the overlapping taxing jurisdictions, the total hospital district proportion of all the other taxing entities in that county, in that area. And so this has been consistent with what we've seen in prior years. Central Health hasn't changed much as it relates to the total burden of the tax bill. We will work on a few more metrics that we compare ourselves to as it relates to the other hospital districts, but wanted to just show this slide with the updated information. Next slide. So despite the COVID-19 pandemic, Central Health has engaged in a robust community engagement process during our budget development. Thus far in this year, there have been almost 400 members that have participated in events that Central Health has held. Some of the feedback themes that we have heard as it relates to those events are related to the COVID-19 pandemic, making testing accessible to high-risk populations, the prioritization of healthcare facilities in underserved areas of Travis County, and shortening the amount of time it takes to process an online MAP enrollment application. I think these are all areas that Central Health is addressing. And I think in our upcoming budget, we continue to address those issues. I will say, and I think you heard the Dean mention this, that Community Care has been an outstanding partner and service provider as far as the COVID-19 testing that they've provided to the community. But there's a full report that is available and will be provided to the board members if it hasn't already been provided. But I certainly wanted to mention kudos to the outreach staff that has, to some degree, not looked at COVID-19 as an impediment, but as an opportunity to further community engagement. Next slide, please. I'm going to turn it over to Lisa to run through some of the numbers as it relates to our budget. Lisa?
Okay, thank you. Sorry, I went too far. Good evening, managers. I'm going to hit some highlights tonight. I just wanted to let you know that we've not changed any of the numbers in the proposed budget. We are still proposing 6.9% over the M&O no new revenue rate. The total rate we're proposing is still, as read in the opening remarks, going to be at a maximum of 11.03 $0.306 per $100 evaluation. We estimate about a $25 a month impact to the average homeowner, and we maintain our highest level of exemption and an $85,000, $500 over 65 and disability exemption. Just a final update comparing this year's budget to last year's budget. We are starting the year, we've talked about this in several meetings, with a contingency reserve carry forward of $115 million, as well as an additional $20 million in property taxes for total sources of funds next year of $367 million. And as Jeff talked about, and we've shared in the past with our long-term planning, contingency reserves are used to structurally balance the budget and to manage long-term needs as well as one-time timing differences. So those funds are then appropriated in healthcare delivery, so $367 million, and of that, $354 million in our healthcare delivery program. We're staying relatively flat in our administration and tax collection, just some incremental increases. And then we also maintain our emergency reserve, which is 15% of eligible expenses. We did have an additional budget, almost $18 million in healthcare services, as outlined with the specific variances here. This also does include a proposed community healthcare initiatives fund and additional funds, $1.6 million for our ACA premium assistance program. And then finally, a $9.5 million transfer to the capital reserve for cash needed for capital transactions, and contingency reserve of $85 million, and a proposed hospital services reserve of $4 million. Again, our total healthcare delivery is estimated and is in our budget, our proposed budget, $354 million. Administration, again, at $10.9 million, relatively flat year over year, as well as appraisal district and tax collection expenses, just some incremental changes. Finally, I'd also like to just address again the capital budget. You'll see in the third column, we do have $9.5 million in additional reserves for expenses. However, we do anticipate between potential 3 new clinic locations, Red River realignment, and continuing to support our electronic health record and additional technology and facility improvements, potentially over $20 million, $22.5 million in capital expenses, and much of that would be debt financed as appropriate. So this is our high-level plan as we go into next year for reserves and potential debt financing. We shared this slide with the commissioners, and you are aware that was that yesterday? I almost said last week. Yesterday.
Yes.
Did approve. Seems like a week ago. It's referred to here as the Popham site, but it's on Elroy Road. The purchase of that property was approved, and we have outlined here those purchases as well as our clinical locations for you to see as the expansion and planning continues in Eastern Travis County. Looking forward, we again are asking for the action in items, I believe items 3 and 4 tonight. As well, we will continue. I would also like to echo Jeff's comments and thank our outreach partners and the TED's whole team. They've done a great job. They've always been supportive, but the robust report on community engagement that you received around the budget is very informative, and we continue to do that work year-round to support feedback into our strategies that are ultimately funded in our budgeting process. We will have another community conversation. We had one in May. Beginning of this process, we'll have another one on Monday continuing to get more information from the community about the proposed budget. We are only required to have one public hearing this year. However, we will take public input at our September 2nd meeting. We want to continue to provide ample opportunities for the community to come forward and share information. And then finally, as we talked about, we will have our required public hearing. We will encourage people to participate via teleconference, but that will be also opened up at our Cesar Chavez location on the 9th. And then come back to you, we hope, on the 16th for the final vote on the tax rate and adoption that will go to the Commissioner's Court September 29th. So we're happy to answer any questions. Again, as we start this process or continue through it, really appreciate the questions. And I would like to just address, there were a couple questions last week, Manager Valadez and Manager Jones, that I'm just getting out to you tonight or tomorrow morning. So I did get those questions, wrote them down, and I'm working on getting those to you from last week.
Thank you very much. Thank you, Jeff and Lisa. Jeff, did you have anything else to add at this point? I guess I'm not hearing him. Okay, so nothing else, Jeff?
No, this is just the time where we have a lot of meetings and a lot of compression.
Right.
Thank you very much.
So thank you for the presentation. I also want to note the robust, as you did, outreach and engagement, particularly always important, and I'm glad to see that we were able with COVID to have that. And I think, as you noted, and I see I see Ted Burton on here, that we have, and his staff, that we have learned some new ways and methodologies of outreach that I think will stand us in good stead going forward. But I know that this is a great deal of work, Lisa and Jeff, for you and others, staff members who we're not seeing here. So thank you to all of you. Members, we'll open it up to questions at this point. So I am scanning. Members, if you have questions, Manager Musaitif, I see, and then Manager Valadez.
Thank you. Thank you, Lisa and Jeff. Really enjoyed it. To me, it's really about serving the people and providing more care, and especially now with COVID-19, it really amplified the inequities and also made us look at different things and how we address health. Now, what the vote is for this evening, is it for the tax rate? Because for the 6.9 or not to exceed? So that was, just wanted further clarification on the actual vote. Thanks.
Yes, let me clarify that. So this is a vote to set the maximum rate for the fiscal year 21 budget. It does, so you're setting a rate of the 11.0306 cents that we've used in our proposed budget, and you're voting to set the rate up to that. Now, that doesn't mean that the rate you eventually could approve could be lower. That's not saying that at all. It's just setting a ceiling for the tax rate for the upcoming fiscal year 21 approved budget. And it starts off a notice process for us. So once this vote, we're eagerly waiting the vote, and then we will rush out and do a public notice, a required public notice to the public that starts off our public hearing process.
I understand. And the difference between fiscal year 20 and 21, can you repeat that?
Well, there wasn't really a difference. We've had a little bit of difference on how we characterize the increase from year to year. Historically, it's been an increase of what was called the effective tax rate. But SB2 has has changed a lot of the terminology and has also changed slightly the approach that we're taking as far as setting a ceiling on our tax rate. So instead of having a percentage increase, we're just setting a maximum rate or a rate.
Okay. So my point is just wanted to see if there will be an additional burden on homeowners. And so that was really.
Oh, yes. Well, I think in that one, if we could go back to that one slide, we showed the
$25.
increase, right? It's about $25. It's a increase on the average taxable value from year to year. So I think we had the values on that slide and the impact. I believe the average homestead value is about $345,000. Let's see. It's $355,000. So for fiscal year 21, the impact at this tax rate would be almost $25.
For a home of 325?
$355,000.
55.
And that's $25 for
the entire year. It's
the entire year. Yes, I wanted to make sure that was clear.
Well, about $2 a month is kind of
Thank you.
round calculation.
Okay, so that's the impact on our on residents. Just wanted to further clarify.
Again, the average homestead value. So
I
Correct,
understand.
the average. Okay, thank you.
Thank you.
Manager Valdez?
Very quick.
If I may, Chair.
Yes, please, please.
Manager Musaitis, just to add a little bit to what Jeff was saying, all of the issues that you raised about the percentage increase and the amount of increase, all of that is covered in the public notice we're required to publish by next week. And you will see that. It will also be on our website. It will be something that you will see a great deal of detail on before the next two meetings.
Yes.
Thank you so much.
Yes, ma'am.
Yes, and this is all following statutory, this is all following procedures that are outlined in statute, and the statute did change because of Senate Bill 2, so that's why you're seeing a little bit different terminology, but this is all following statute. Manager Valadez?
That's just one quick one. Did the contingency fund line disappear? I was just wondering, I didn't see any numbers there. Maybe I'm blind.
No, ma'am. On the, sorry, we don't have these numbered, but.
I've seen them in the past. That hasn't changed, basically. I could just look at a previous one. Is that correct? They didn't show up, is that right?
Yeah, Lisa, can you?
Yeah, I thought we saw them, Lisa, the contingency reserve. Didn't you go over that?
Can we pull that slide up?
The expense on the uses?
Yes. Yeah, Schedule B, yes.
Okay. Went one too far. There you go. It's right. Can you see my cursor? Right here, we appropriate.
You'll have to share your screen, Lisa, because I stopped it.
Oh, okay. I'm sorry. Okay, there you go. Sorry, just assumed it was
no worries. Thank you, Lisa.
Yes. So the contingency reserve appropriation is right here. You see
Okay.
that?
I think I may have been looking at another slide. Is there another slide where that comes up at the bottom?
It comes up as a use of funds as the carry forward.
There.
And then it's appropriated, I'm sorry, as a source of funds as the carry forward. This is when we shared with you in previous meetings where we estimate we're going to end the year, a very high level estimate. We're trying to estimate where we're going to end the year. That those dollars will be available as a source of funds next year. And then those will be primarily put back into healthcare.
And that's why they're at the bottom where it says reserves ending balance, contingency reserve.
Oh, I apologize. Yep, we'll update that.
That's what I'm referring to.
Yep.
I thought I was going blind. And then one more thing, and I don't know who can best answer this. Can someone tell me what the estimated time is from the time someone signs up to be a MAP patient to the time they actually get in to be seen by a doctor? For me, that's kind of a wait time. When people are signing up for MAP, they're signing up for MAP because they have a great need. And I don't know if I've asked this before, but I thought I had.
Manager Valdez, is this, I don't know that that is something that falls under this item, David.
I thought it was in something where it talked about MAP. In the budget, it talked about MAP.
So there.
That's why I'm asking the question.
Okay, let's see if we have the response. But this may.
I don't know that it's covered in the budget to the extent that there's a performance measure that goes down to that level of detail for the budget. I think.
Well, so I'm going to, and David, stop me if you need to. So that was one of the findings in the community engagement, was the time for online registration. So as you know, in COVID-19, as it relates to that, we had to suspend temporarily some in-person enrollment. We extended the eligibility period, and we began a robust online eligibility process. You know, rightly so, as new things, especially technology, occur, it probably was taking longer than it needed to. But I think we're making amends to smooth that process and quicken it up much more effectively and efficiently. Now, your question was from enrollment period to seeing a doctor. I'm going to ask John Morgan, I think he's on the call, if he might have a little bit better information as it relates to, I think, enrollment to either treatment or the initial visit, I think is your question.
Right. I didn't think, Jeff, that you would have that under the budget. Okay. Is John on?
I am. Yes, ma'am. Can you hear me?
Yes, we can. If you need to get back to us with the information, that's fine.
I will absolutely get back with you with more exact information.
I can't hear you now, John.
And, can you hear me any better, Manager Greenberg?
Yes.
Great. So we, just to reiterate something Jeff said, we did experience some longer than normal wait times as we transitioned to a online application and primarily to telephonic-based enrollment support. That happened at the same time as some of the automatic extensions expiring and increased the number of applications that we were getting. Things have largely returned to normal with processing within 1 to 2, maybe 3 days. I don't have the exact up-to-date turnaround time right now, and a lot of times it depends on the time of day it's submitted and if the application is complete. The time between enrollment and an appointment is a very different scenario. That's usually driven by capacity at the clinics and capacity at the individual clinic that you're looking for an appointment with, or the individual provider you're looking for an appointment with, is really what's going to drive that time frame. We do track a metric called third next available. It's kind of the national standard. I can provide some of that summary information for our primary care system. In general, it averages in our system between 10 and 20 days. Some clinics are out past that. Some clinics have next day access. And then of course we have walk-in sites at community care at Southeast Health and Wellness, as well as the Hancock Center, as well as our urgent care facilities that also have same day availability.
Thank you, John. Members, other questions at this point? I'm scanning. Can we get the full screen back? Is that something we can do so I can see everyone? Lisa, I think you have to quit sharing. Yes, thank you. Members, other questions at this time? I'm scanning.
Chair, I have a quick question.
Yes.
I I don't know which budget, or maybe I can call, reach out to Lisa or Jeff. Within the budget line, which one addresses the social services that we're doing, the public health work that we're working on? So which line are we getting this money out of? So for right now, for the contact tracing work that it's being done, for the other, so where is that coming from? What service line?
Well, so you're specifically asking about contact tracing and
Not just specifically, any of the public health work that Central Health is right now conducting, where is it coming from?
Can I ask, as it relates to COVID-19, is that what
Yes.
you're asking? Yes, okay. Thanks for that clarification. So both Central Health and Community Care are in the process of applying and actually being approved for FEMA public assistance. And so some of these activities will be eligible for public assistance. At this time, we don't know to what extent that reimbursement will be. Typically, FEMA public assistance reimburses you for 75% of eligible expenses. So we are out seeking that, federal type of reimbursement, federal or state reimbursement. There's not a specific line for that because we just simply don't know what the amount could be. And if we do have to fund that, it would come from our contingency reserve. So there are a couple of somewhat convoluted funding streams that have occurred. First of all, Community Care has received about $5.5 million of HRSA funding, some which might be eligible for some of the activities, specifically the contact tracing, but certainly for testing. Again, there's...
Oh, I apologize, Jeff. Go ahead.
Well, I'm probably giving you more complicated answer than you ever would have thought you were asking. And the point is, it's a pretty complicated reimbursement process. And so we don't per se have a budget line specifically for COVID-19 because we simply don't know what that ultimate cost will be. And there are certainly additional funding streams.
Yes. So Jeff,
approved, in the hopefully very near or foreseeable future.
So really, I'll follow up with you, but my concern is, like, for instance, when the city asks us to step in, like right now with Hurricane Laura, for instance, and other services. So where are these funds coming from? Do we have a budget line item to address these issues? So I just, for further transparency and clarity. So that's really my ask.
And I think my simple answer would be it's in the contingency reserve. Mm-hmm. And any amount that we spend that is not reimbursed we would bring that forward, and it would be funded from the contingency reserve.
Thank you, Jeff. Members, anything else? Okay. If not, I believe that we need a motion and a roll call vote, correct, Jeff?
Yes, that's correct.
Is there a motion, members, on the board approving a proposed property tax rate? Manager Bell.
I move that the board approve a proposed property tax rate of no more than 11.0306 cents per $100 of taxable property value for the 2020 tax year, which will support Central Health's fiscal year 2021 budget.
There's a motion. Is there a second? Second, Manager Musaitis. Okay. So we will now have a roll call vote. We have a motion from Manager Bell, a second from Manager Musaitis. Ms. Brianna Yanes will now assist me in taking a roll call vote. For the roll call vote, Ms. Yanes, will call the name of each board member in attendance in alphabetical order. Each board member must indicate whether they are voting yay or nay or abstaining from a vote on the proposed tax rate increase. The Shanes will confirm your vote before moving on to the next member to ensure we have an accurate vote tally.
Okay, members, I will read each of your names in alphabetical order. When your name is called, please unmute your phone or computer and state your vote as A or yes to vote for the motion, nay or no to vote against the motion, or abstain if you wish to be counted as present and not voting on the motion. After you have stated your vote, I will repeat it and wait a few moments to ensure you do not wish to dispute the vote as I heard it. Please speak up if I have misstated your desired vote. With that, I will call the roll. Vice Chair Dr. Charles Bell.
Yes.
Dr. Bell votes yes. Okay. Chairperson Sherry Greenberg.
Yes.
Chairperson Greenberg votes yes. Manager Shannon Jones.
Yes.
Manager Jones votes yes. Manager Murad Musaitif.
Yes.
Manager Musaitif votes yes. Treasurer Julie Oliver.
Yes.
Treasurer Oliver votes yes. Secretary Cynthia Valadez.
Yes.
Secretary Valadez votes yes. Manager Dr. Guadalupe Zamora.
Yes.
Manager Dr. Zamora votes yes. Manager Julie Zuniga.
Yes.
Manager Zuniga votes yes.
Thank you. Thank you, members. Appreciate the attention to this matter. And I believe we also need to have a motion on the public hearing, right, under agenda item number 4. Is that correct, Mr. Duncan?
Yes, ma'am.
Is there a motion? Yes, Manager Bell.
I move that the public hearing on the proposed tax rate increase be held on Wednesday, September 9th, 2020 at 5:30 p.m. at Central Health's Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and virtually online via a web link and phone number to be posted on the Central Health website and published in a general circulation newspaper in Travis County.
Second.
We have a motion from Manager Bell, a second from Manager Valadez. All in favor? Aye.
Aye.
Yes. Opposed, same sign. Any abstaining? Thank you, members. We have now set the public hearing. We will now take up item number 6. Discuss and take appropriate action regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions and the creation of a new line of business beyond healthcare coverage benefits. Wes will be presenting. Wes, are you with us?
Yes, thank you.
Thank you.
I will ask if I should share a slide or if there were, I believe there was a slide in the packets, but I don't know if that's easier for me to share or if that's something that
Already showing
It's
well.
being shared.
already sharing.
We
Okay,
see it.
thanks.
Yes.
We see it. Perfect. So we'll just review this one slide summary of where we are to follow up on discussions from last time. We appreciate your time on this matter. So as the CHAP program has proved successful, providing economic coverage to formerly uninsureds, Sendero is working to develop a low-risk way to share this program with other communities. Under the working title of the Indigent Healthcare Initiative, Sendero would create a subsidiary to manage and administer the program. Sendero would be paid for its services with the opportunity to share in the financial success of the program. The structure of a subsidiary safely separates the funding and operations of Sendero from the subsidiary in this new business. Development funding for this program is coming from other funds, such as last year's net income, so that no central health capital contributions are used. This program would in turn strengthen Sendero financially while sharing the many benefits of the CHAP program and generating new funding for Sendero. This new funding increases financial stability and reduces overall cost for people in our area for Sendero. To enable this initiative, Sendero and its board is requesting the Central Health Board of the Managers to approve a few key actions. These requested actions, will have to defer to the attorneys for the actual wordings, but you can think of them roughly as some amendments to our corporate articles to support this new line of business and activity in other geographic areas, and to specifically, per our bylaws as it was envisioned when we were set up, that would be allowed to create a subsidiary appropriate to engage in this new line of business and protect Sendero's status. So with that, I would ask maybe if there are any questions, or if the attorneys feel that I have missed something.
Managers, are there any questions? I know we had a previous discussion on this. Manager Valadez?
I don't have a discussion item. I was wondering whether or not a motion can be entertained at this time. No.
I think our counsel, David Duncan, don't you need to read something into the record, David?
We have some reading to do, and I will begin with that. And I believe that the motion originally anticipated that Mr. Giesland would undertake this task, but he is otherwise tied up. So I will begin. This is a resolution of the Travis County Healthcare District, DVA Central Health, acting in its capacity as sole member of Sendero Health Plans, Inc. Will be dated tonight, August 26th, 2020. Approval of Indigent Coverage Program Expansion Initiative. Whereas Travis County Health District, DVA Central Health, Central Health, is the sole member of Sendero Health Plans, Inc., a Texas nonprofit corporation that operates and managed healthcare plan for the benefit of, to perform the functions of, and to carry out the purposes of Central Health, Sendero. Whereas Sendero has developed and operates a program the Indigent Coverage Program, the objectives of which are to A, make health insurance coverage available for low-income and high-risk uninsured individuals in Travis County, Texas, and certain surrounding communities, the Sendero communities, and B, provide safety net healthcare providers serving such patient population with reimbursement for their services, which they otherwise would have received minimal, if any, reimbursement for indigent care, the ICP objectives. Whereas the Indigent Coverage Program has proven successful in achieving the ICP objectives in the Sendero communities. Whereas the Board of Directors of Sendero believes that it is important to share Sendero's expertise relating to the Indigent Coverage Program with communities outside of Sendero community, the Sendero community, in a manner that provides Sendero with an opportunity to increase its revenues and offset its operating expenses, the ICP Expansion Initiative. Whereas the ICP Expansion Initiative involves the geographic expansion of Sendero's business and/or the initiation of ICP Expansion Initiative as a new line of business of Sendero beyond healthcare coverage benefits. Whereas in order for Sendero to engage in the ICP Expansion Initiative for the benefit of communities outside the Sendero communities, the purposes and mission of Sendero as set forth in Sendero's Certificate of Formation and bylaws must be modified to authorize Sendero to directly or indirectly through a wholly owned subsidiary engage in activities in furtherance of developing, implementing, and managing the Indigent Coverage Program and achieving the ICP objectives in and for the benefit of such other communities. Whereas the Board of Directors of Sendero has heretofore approved and authorized Sendero to pursue, carry out, and accomplish the ICP Expansion Initiative as a new line of business, and take other actions required in connection therewith as set forth in the these whereas clauses and the resolutions below, and as otherwise necessary or advisable to carry out the intent and accomplishes the purposes of the foregoing, subject to the authorization and approval of Central Health as the sole member of Sendero. And whereas, pursuant to Section 3 of Article 2 of the bylaws of Sendero, the approval of Central Health is required to authorize the 1, amendment of the Certificate of Formation and bylaws of Sendero, 2, creation of or investment in any subsidiary entity of Sendero, and 3, geographic expansion of Sendero's business and the initiation of a new line of business beyond healthcare coverage benefits. Now, therefore, it is hereby resolved that Central Health hereby approves and authorizes Sendero to engage in such activities and to take such actions as are necessary or appropriate to pursue, carry out, and accomplish the ICP expansion initiative as a new line of business of Sendero beyond the provision of healthcare coverage benefits, which new line of business inherently involves geographic expansion of Sendero's business, subject to Sendero's accomplishing the requisite amendments of its governance documents as hereby authorized by Central Health through these resolutions, provided that such activities and actions shall not involve 1, Sendero taking any action or accepting any obligation relating to any financial obligation or financial investment in any risk-bearing licensed managed care or health plan entities, or 2, the assumption of underwriting risk by Sendero outside of the Sendero communities. And it is further resolved that Central Health hereby authorizes the amendment of Sendero's certificate of formation to modify Sendero's purposes as set forth in Exhibit A hereto. And it is further resolved that Central Health hereby authorizes the amendment of Sendero's bylaws as set forth in Exhibit B hereto. And it is further resolved that Central Health hereby authorizes Sendero to form one or more wholly owned subsidiaries, either in the form of a nonprofit, a for-profit or nonprofit corporation, or a limited liability company, as Sendero's management shall determine to be the most beneficial and appropriate for Sendero, to A, serve as the manager for the indigent coverage program conducted in geographies outside of Sendero communities, and provide necessary and appropriate management and administrative services and other support in connection with carrying out the ICP expansion initiative in communities outside of the Sendero community, and B, hold equity or other ownership interests in entities, including licensed managed care and health plan entities that are participants in the indigent coverage program in such other communities. And it is further resolved that Central Health hereby authorizes, approves, and directs the board of directors and officers of Sendero, including the executive director and other senior management and staff of Sendero selected by the executive director, to take such additional actions as they may deem to be necessary or advisable to carry out the intent and accomplishes the purposes of the foregoing resolutions, including but not limited to the executive director and other officers of Sendero, A, executing and delivering on behalf of Sendero all such documents, agreements, instruments, B, making such modifications to the language of the proposed amendments of Sendero's articles of formation and or amended and restated bylaws as set forth in Exhibits A and B hereto, respectively, consistent with the intent of Central Health and the Sendero board and the foregoing resolution, as the executive director and such other officers believe, based on advice of Sendero's legal counsel and as may be required by governmental agencies, is necessary or advisable to comply with law and maintain Sendero's status as an organization exempt from federal income tax under Section 501c3 of the Internal Revenue Code of 1986 as amended, the code, and as a public charity within the meaning of Section 509A of the code. C, filing documents with governmental agencies. D, notifying the Internal Revenue Service regarding expansion of the scope of Sendero's purposes. And E, incurring such fees and expenses as they deem necessary or advisable to carry out the intent of these resolutions. I'll go ahead and read the exhibits. Exhibit A is the amended and restated certificate of formation. The first paragraph of Article 5, when purposes of Sendero's articles of formation, shall be amended to read in its entirety. The corporation is organized and operated exclusively for the charitable purposes of A, operating for the benefit of, performing the functions of, carrying out the purposes of, and lessening the burdens of the Travis County Healthcare District, DBA Central Health, a governmental unit, and such entity being an entity described in Section 509A1 of the Internal Revenue Code of 1986 as amended code, and B, more broadly, engaging in activities either directly or through one or more controlled affiliates aimed at promoting increased access to affordable, quality, comprehensive healthcare services to low-income, underinsured, and uninsured patient populations. Sendero is intended to qualify as a Type 1 supporting organization as described in Section 509A3 of the code. Exhibit B, amended and restated bylaws. The preamble to Sendero's amended and restated bylaws shall be amended in its entirety to read as follows. It shall be the mission of the corporation to 1, arrange or provide healthcare services to residents be residents served by the Travis County Healthcare District, and to provide people living in the community surrounding Travis County as authorized by the state of Texas by establishing a health maintenance organization committed to A, promoting individual and family health by making available comprehensive healthcare services to meet the needs of the person served, B, developing community-oriented primary care and preventative healthcare programs that reduce the incidence of illness and injury and promote wellness, and C, establishing linkages between community providers and the HMO that serve to improve accessibility and quality while reducing the cost of service, and 2, more broadly engaging in activities either directly or through one or more controlled affiliates aimed at promoting increased access to affordable, quality, comprehensive healthcare services to low-income, underinsured, and uninsured patient populations.
Manager Valdez, would you like to be recognized for the board to adopt the resolution that was read into the record by Mr. Duncan?
I'll second it if Dr. Bell is going to make the motion.
Dr. Bell, would you like to make the motion?
I move that the board adopt the resolution read into the record by Mr. Duncan.
Manager Valadez? Okay, so we have a motion by Manager Bell. We have a second by Manager Valadez. All in favor, please signify.
Aye.
Aye. Aye. Opposed, same sign. Any abstentions? All right. One abstention. Manager Jones, show Manager Jones abstaining. All right, members, thank you very much. Our next item is receive and discuss updates on the 1115 Medicaid waiver delivery system reform incentive payment (DSRIP projects and the community care collaborative, including healthcare delivery arrangements and other community partnerships. I announce that the board is convening in closed session to discuss agenda item 5 under Texas Government Code section 551.071, consultation with attorney, and section 551.085, governing board of certain providers of healthcare services. Members?
Manager Greenberg, I'm just letting you know I'm going to have to leave the meeting at this point.
Okay, thank you, Manager Jones. Appreciate the update. Members, you will need to log off here completely. You have a separate log on for the closed session. The time is now 7:14, I'll call it 7:15. Would you like a 5-minute break, a 10-minute break? Do we need some kind of break here?
5 minutes.
5-minute break?
Yes,
okay,
please.
so let's convene then at 7:20 on our closed session. Thank you, members.
Thank you.
Okay. Do we have a quorum present?
Yes, ma'am.
Yes.
Looks that way to me. Okay. The time is now 8:48 and we are out of closed session. We are back in Open session, no motion is necessary. We are at item number 7, confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting, which will include a public input session regarding our proposed tax rate increase, is scheduled for next Wednesday, September 2nd, 2020 at 5:30 p.m. remotely by video conference. At this time, I'm ready to accept a motion for adjournment.
So moved.
I didn't hear that Manager Valadez moves adjournment. I see Manager Bell, a second. All in favor? Aye. Aye. Opposed, same sign. Abstaining. We are adjourned. Thank you, everyone.
Bye, everyone.
Thank you, members.